Towards the end of our course, you might not be able to memorize all these precious information we went through, but in this last lecture, we'll be discussing the key points for the exam. And I need to emphasize that you need to memorize these trials and these studies as a story, as if telling a historical anecdote. So we'll start today by clinical trials in AMD. So let's first imagine you were working in the NHS on 1950s, and in your clinic you examined a patient with CNV, with age-related macular degeneration. How would you treat him? So you can't treat him, just observation. In 1961, FFA was introduced, and CNV was recognized clinically and then geographically, and a treatment needed to be sought. So there was the xenon arc. They tried the xenon arc to target the CNV if it was extrafoveal, but it led to severe deciform scarring. In 1980s, there was what's called the MPS, macular photocoagulation study. So this study designed certain indications for laser, argon or krypton laser photocoagulation. And actually, this left deciform scarring as well, but because this set up criteria for treatment, deciform scarring, so subfoveal CNV was not treated by laser, for example, and this makes sense. Then they tried to find some sort of treatment that would help patients with AMD. So in 1999, there was the TAP study, and this is the first important study to move. So this introduced PDT, photodynamic therapy, as a treatment for wet age-related macular degeneration. Shortly after, pigaptanib sodium was introduced into practice. So they tried it in what was called the VISION study. However, this did not work. So it had small benefit on treatment of CNV. After pigaptanib sodium, ranibizumab was introduced. And they were shy or were reluctant to try ranibizumab alone. So they didn't repeat the VISION study, but they did what was called the FRCOphth study. As we discussed previously, they compared ranibizumab and PDT versus PDT alone. And they proved that ranibizumab is a good addition to the treatment. So FRCOphth study is a basic study that introduced ranibizumab into the NICE guidelines and into the Royal College policies and guidelines for treatment. The focus then shifted into ranibizumab. So they started the ANCHO study. They wanted to reduce the cost because administering ranibizumab and PDT for every patient with age-related macular degeneration is a costly process. So in the ANCHOR study, they proved that monthly ranibizumab is better than PDT for treatment of wet age-related macular degeneration. Then they started the MARINA study. In the MARINA study, they proved that ranibizumab is better than sham injections. Then they wanted to reduce the costs more, so they started the PIA study. But in PIA study, they reduced the monthly dosing of ranibizumab in ANCHOR and MARINA to quarterly, every 3 months. Quarterly ranibizumab. However, this didn't work. So quarterly ranibizumab was inferior to monthly injections. So they wanted to develop something cheaper. They introduced the PRONTO study. So they introduced the PRN protocol. They proved that PRN ranibizumab compared to monthly ranibizumab. Then further or newer intravitreal injections were introduced, like aflibercept. So they introduced the VIEW 1 and VIEW 2 studies to prove that aflibercept is a valid option for NICE guidelines on aflibercept. In this time, a disease that's called PCV, polypoidal choroidal vasculopathy, they wanted to do a study on. So they carried out the EVEREST study, EVEREST 1 and EVEREST 2. And this study proved that ranibizumab plus PDT is superior to ranibizumab alone. Proved that monthly ranibizumab alone is better than PDT, while the EVEREST study proved that ranibizumab and PDT are superior to ranibizumab alone in PCV. Other studies, like Hawk and Harrier, introduced brolucizumab comparing it to aflibercept. So it was not inferior to aflibercept.